Hello, welcome. I'm Dr. David Bernard, Children's of Alabama. I'm a child abuse pediatrician as well. I'm a pediatric emergency physician. And I'm here today just to give you a little overview of child abuse and hopefully can convince you why it's important to you, even though you have no experience with my specialty. I'm involved with our CHIPS Center, which is a children's hospital intervention and prevention services. It's our child abuse clinic, and that's where I do most of my work at this point. Our talk will kind of, hopefully at the beginning, convince you of the why this is important to you, why it should be important to you. And then we'll proceed to really give you a brief overview of the medical evaluation of sexual abuse and then the medical evaluation of physical abuse. Right? These are the required disclaimers. Have nothing to disclose. Sorry about that. That was kind of quick. Nothing to disclose. No commercial products. No FDA non-use, right? And no relevant financial arrangements or commercial affiliations. So, why the area of child abuse is important is because it's really common. It's more common than those things you probably see all the time, like asthma, sickle cell disease, and at least 10% of children per year experience it, with 1 in 5 females and 1 in 11 males report childhood sexual abuse, and a quarter of the adults in this country have reported some type of victimization, with neglect being most common, physical abuse followed by sexual abuse. All right. Number one reason why this is important is you are a mandated reporter, almost certainly if you're working in the hospital environment. And the mandated reporter code for Alabama and for most states is pretty similar. You just have to have a reasonable suspicion, not a proven suspicion that abuse might be occurring. All right? And a report must be filed. It is a law in every state when there is suspected abuse that a report is filed. And there's very few exceptions to that rule. In Alabama, it's clergy and attorney privileges. Right? So this is the list of the people that are prescribed within the mandated reporter law. And I expect that list is pretty exhaustive and it encompasses all of you in the audience. Right? We'll stop to talk about self-care for just a minute. For anyone that's exposed to the stories of childhood trauma, remembering your self-care is really, really important because these are things we are not meant to hear and see. Unfortunately, it exists in our society, and some of us are privileged to take care of these children in particular, but we are not meant to hear and see these stories, and we don't hear these stories without it causing some concern and changes in us. So don't forget your happy place. I know most of you would probably be in a place like this rather than listening to me right now, but at least you can go there when you need to mentally. The second reason why I want to convince you that this is important to you is something known as the Adverse Childhood Experiences Study. And so back in the 1990s, 13 or 14,000 people surveyed at their primary care office and looked at their health outcomes based on their childhood adverse experiences. And they noted that adverse experiences lumped them into several different categories. 7 of them, won't go through all of them, but really physical abuse, sexual abuse, family dysfunction. And what they found is that the more adverse experiences you had, the more likely you were to have adult illness, right? So you can look at if you go from left to right on the graphs, the number of adverse experiences, the higher you go, the more likely you are to have a range of mental health problems that's somewhat easy to understand. And certainly children with adverse experiences, the more they go, higher they have, what they call their ACE score. If you have 4 or more adverse experiences, your risk of committing suicide is exponentially higher. What was really surprising is you as an adult and your risk of chronic disease. And that is, look at your adverse experiences, and the higher your adverse experiences are, the more likely you are to have heart disease, diabetes, chronic lung disease, and even strokes. Why does that occur? Well, one of the reasons it occurs is that all the stress hormones that are released when a child experiences adverse experience, the biochemical changes that occur actually rewire the brain and the body and lead to greater disease and such. And so what we know is that children who experience adverse experiences, they don't necessarily get over them, that it affects their health. But we also know that there's this concept of resilience, right? The capacity to cope with life stresses. And our research has shown that one of the most important factors, if not the most important factor in a child developing resilience, is having at least one adult in that life that believes in them, provides a stable environment, whether it's a caregiver, a parent, or someone external to them. So that means that all of us could be in the position at some point of supporting a child through our practices and whatever, that might be one of those adults that allows them to develop the resilience that leads to them not being affected too terribly the rest of their life by their adverse childhood experiences. So think of that. It's very powerful that all of us could be in that position to affect a child's life. Okay. Onward to, I like to talk about child abuse from the perspective of mythology. What are the things we think we can believe? Because there are a lot of false beliefs out there. And then we'll give you some information that helps counter those beliefs. All right, so some of those beliefs is that the only reason we do these exams is to do it to see if it happened for a court of law, right? That the purpose of getting examined in the process of examination for a child will lead to additional trauma, right? That any medical provider can provide these type of exams to a child, right? And in fact, that we're such powerful medical providers, we can perform a sex test on our teenagers and see if they're sexually active, right? Most people believe that if a child was sexually abused, there would be some physical evidence, right? And most people are worried about strangers in the terms of sexual abuse in their children. It's not true. And then there tends to be this mindset that people are so uncomfortable with the possibility of sexual abuse in children and with things that could go wrong with children's genitalia in particular, that anytime something goes wrong with the child's genitals, they immediately jump to sexual abuse as being a likely possibility there. It turns out that there's lots of things that can go wrong with children's genitalia that has nothing to do with sexual abuse, and it's incumbent upon us, particularly those who specialize in this area, to determine what could be sexual abuse and what is just a normal medical condition. So the way our field developed, there used to be, if there was suspicions for abuse for whatever reasons, disclosures, behaviors and such, then they would bring them to a medical provider to see if it really happened. And that's how our field started 50 to 60 years ago, that if there was abuse, we must be able to tell with a medical examination. So we've learned a lot since then. Our field's still pretty young, so it's really the mandated reporter statutes is when we really started to see and discover these patients. It was really only at the end of the 20th century that we began to recognize the science behind the evaluation of children who were sexually abused, that we began to use our specialized equipment known as the colposcope, that we began to collate the research, and in fact it was only at the beginning of this century that we had the first article, the Adams classification system, that really stratified and began to teach people what you would expect on a child's body if they've been exposed to sexual abuse. We say the first colposcope was used in sexual abuse exams, and in 1985 the first Child Advocacy Center opened. That was in Huntsville, Alabama, so for you Alabama folks, that's a place we can, a thing we can be very proud of because that established the national standard that exists to this day for the evaluation of sexual abuse in children. Right. But the thing we know is, this was a seminal study that's been repeated multiple times, is that looking at thousands of children referred for medical examinations for sexual abuse, that regardless of why they were referred, whether disclosures, whether other doctors were concerned they were abused, whether they had disclosed penetration or not, that the overwhelming majority of time their bodies did not show evidence of that sexual abuse, that their medical examination neither confirmed nor corroborated that abuse. You can see the 94.5% of the children with severe abuse had normal exams that by definition the child had disclosed genital to genital penetration. And so what we've known is that what we have learned is the concept of normal to be normal. And that is children's bodies, when there's been a disclosure of sexual abuse, in the majority of times will not have medical findings that confirm that abuse. And in fact, the concluding paragraph from this seminal study, and I will not read it to you, but is that really it's the history from the child, done in an appropriate fashion, obtained in an appropriate fashion, which will be the evidence of whether sexual abuse occurred. It is not the medical examination. So the term we use is normal to be normal, that children who've experienced sexual abuse will have normal bodies. And then the question comes up is why does that occur? And in general, children who are abused by someone that is known to them, not a stranger, and they're abused in ways that don't harm their bodies. There is lots of touching and genital contact that is not full penetration that would be expected to damage. Even when these tissues are contacted by genitals, we think about them like the mucosal tissue inside your mouth, and that when you bite your cheek, it hurts, might bleed, but it heals fully and completely within just a couple of days. And so you will not see evidence of that. DNA is very rare in children, and in fact, there's so much sexual abuse now that occurs with pornography exposure, sexually explicit content exposure. You would never expect a child to have any abnormalities because of that. Right? So the one take-home point for this part of the lecture is the normal to be normal, is that medical examination will not confirm the concerns for abuse in children. And so then we start thinking about that, then we start getting to the mythology that most of us were raised with, and that is the mythology of the hymen. And the hymen was the Greek god of the wedding feast, hence its importance when we talk about sexuality. But this myth that the hymen is always ruptured with sexual contact. It turns out that's not true. In fact, the term intact hymen has no meaning whatsoever, and I will explain that further. Most hymenal injuries heal. Many children have very large hymenal diameters normally, so the size of their opening doesn't matter. And hymenal injuries are very rare. When they do occur, which is pretty rare, I see one, just a couple a year in my practice. It does not occur from accidental trauma like horseback riding or tampon insertion. And so when we do have those rare cases where there's been blunt force trauma that's injured a child, we can pretty much be definitive how that might have happened. All children are born with a hymen, right? And so we know that all children have a hymen, and so we know what to look for when we're looking at the genital examinations, right? So we argue for a new paradigm. I've taught you that there's suspicions for abuse. They do get a medical examination, we hope, but our medical examination's not going to tell whether that abuse occurred or not. All right. They need an investigation. That investigation includes a special interview performed at the places called advocacy centers. Huntsville was the first. All right. And that helps determine the details of the abuse. But they need a medical examination, most importantly because we believe, and research sustains that belief, that part of it can be part of the healing process for the family and child. That them knowing that their bodies are healthy with an examination conducted in a non-traumatic fashion really helps them move to the next step for healing. There are occasional complications of abuse, and so a medical examination can detect that. There are medical conditions that get mistaken for abuse. For example, children get strep infections in their genital area just like they get strep throat. Those look awful. When a non-trained provider sees those, they will think the child would have been abused and report them. And so trained providers being able to recognize those conditions is really important. All right? And then occasionally we can identify findings that we call forensic findings, findings that are helpful for the investigation. But the big take-home point is medical examination only rarely provides any corroboration. So then the question is, who should have a medical examination? Given the potential benefit to the child and the family, we feel that if sexual abuse is a reasonable suspicion when it's been investigated, a properly conducted medical evaluation should be performed. And you might know I've used the properly conducted term a couple times. So properly conducted means that it needs to be by a trained provider, because if you're not trained, and we did not get this training in our general medical training on the techniques for examination, photo documentation, evidence collection. I was not taught that, and I hardly know anyone that was taught that in general medical training. But if you're not trained, you don't feel comfortable doing these exams. You might call normal findings abnormal, abnormal findings normal, and you don't recognize the medical conditions that were mistaken for abuse. So it's really, really important that children have examinations by trained providers, right? Unfortunately, trained providers in this field are relatively rare. Does not have to have an MD. Nurse practitioners, forensic nurses, also known as sexual assault nurse examiners, when they've had specific training, can conduct these examinations. They need to utilize child-friendly facilities with the appropriate equipment for photo documentation. Our state is very resource poor for this. There's just a couple of child abuse pediatricians like myself here. We are working to develop pediatric SANE programs across the state, and some are developing. And wherever your practice point is and you're looking for a trained medical provider, your local child advocacy center, CAC for short, can help you identify where's the appropriate place for that child to be seen. The majority of Alabama counties have child advocacy centers, as do the majority of counties in other states. If you're in a county that doesn't have a child advocacy center, they would have partnered with a neighboring child advocacy center to make sure that kid has a specialty place to go for their interviews and exams. Okay. I am now going to show you a couple of illustrations, not genital pictures, so you're not going to see any true genital pictures, but a couple of illustrations to show you how we conduct these examinations. The purpose of these is just for you to know that what we do is not inherently traumatic to the child. Children, once they've been prepared by a trained provider, might on the far left you'll see be laying in what we call a frog leg position so that you can see the external genitalia. We can then use our hands externally to separate those tissues so we can see a little bit more internally. This does not involve pain or discomfort. We don't insert anything into the child. There's no speculum exams or things that would cause discomfort. Or they can sit in a parent's lap and have the same thing. Or sometimes, to get a better view, we can have them on their knees and elbows, and so we can look at their bottoms from behind. None of these are inherently painful, and children tolerate these exams very well across the board. And what we're looking at is so we can describe the normal female genital anatomy. And it's important for us to be able to describe that. We know that at least 50% of primary care practitioners can't describe normal children's genital anatomy. So it's important for us to learn that when we can. And I won't go over all those details, but I did want to point out the hymen for you. So the outer tissue, and most people have heard of the labia, the big and small labia, the mucosal area on the inside known as the vestibule, and then that lining that's known as a hymen. And notice the normal hymen has an opening in it. It is not intact. The normal hymen has an opening there that digits, objects, genitalia can penetrate through without injury in most cases. And in fact, the only intact hymen is a very rare medical condition that babies can be born with, known as imperforate hymen, where there is not an opening in the hymen. And that becomes an emergency medical condition at puberty because there's no place for the menstrual blood to go. And so there's nothing mysterious about that. It's just people are uncomfortable with this anatomy and never learn it. And then the area known as the perineum, which leads you to the bottom, the anus. The anus is a muscle that relaxes with pressure, with other sensations. That's why we're able to have large bowel movements without injuring our anus. And then the genital tissue of boys. The genital anatomy is very soft, what we call spongiosum tissue, and is almost never injured with sexual contact. And the anus for them is almost never injured in sexual contact as well. So the take-home points for those slides is the examination we do is non-traumatic, it's very gentle, we don't have to do anything internal, but allows us to see those important structures and determine if there's any change in the anatomy with that history of abuse. Onward. Talk quickly about forensic evidence. We're all accustomed to our crime shows, and it turns out that most children do not have forensic evidence when their bodies are sampled for that after a sexual assault or sexual abuse, all right? And the reason, because that is time, and that is if you look at the time since an assault and the yield of forensic evidence detection, and you can see very high in the first 6 hours, but drops off to almost nothing after 24 hours, except for occasionally find it on the linen and the clothing that the child was exposed to at the time. So most children do not disclose in the first 24 hours. So virtually most children do not have any forensic evidence to corroborate the suspicions for sexual abuse or sexual assault. Right? Onward to talk about these creatures, and I say creatures, these are adolescents, and I expect any of you who are parents of adolescents will understand that they do crazy things. And so illustrate that the evaluation of sexual assault and sexual abuse in adolescents is a little different, because there is a little difference there. Right, so the adolescents are more common to have injuries, though the majority still don't. And then they have a lot more psychological complications that are quite severe, such as PTSD, which subsequent suicidality. Kids have a lot of behavioral problems that come with it. You have to worry about the consent and statutory issues. In Alabama, the age of consent is 16, so if they're under 16 and they're having reportedly consensual sex with someone over 16, then it could be illegal depending on their age difference. So we have to worry about those. Sexually transmitted infections are much more common in adolescents, up to 5%, as well as pregnancy after a sexual assault, up to 5%. And so in adolescents, we can provide emergency antibiotics and emergency contraception to lessen that risk. Right? Adolescents are more likely to have forensic evidence, still the majority don't. All right? And in children, we typically don't find forensic evidence. When I say children, prepubertal, and we're not in the position to offer post-exposure prophylaxis for them, the emergency contraception or antibiotics, because of their age and because the risk is so low. So there is a difference. And you also have to deal with the consensual sexual contact in adolescence, and that is what we know is that there can be consensual sexual contact that occurs right before non-consensual sexual contact or a sexual assault. And what we know is consensual sexual contact can yield injuries just like sexual assaults. And if you look at the blue line and the green lines, you're almost as likely in every area to have an injury, such as a laceration or an abrasion to the genital tissue with consensual or non-consensual sexual contact. So even medically, when I see injuries, typically in an adolescent, I can't determine whether there was consent involved because those injury patterns look the same. That's an investigatory question for the legal people. So I can't determine. I can determine there were injuries and we can manage appropriately. Okay. So this myth about children being abused by strangers, this is some local Alabama data in Tuscaloosa looking at who was the relationship of the perpetrator to the victim, and you can see almost always known. And this was a private pediatrician in practice who gathered this data, almost always known, all the way up to, and almost always males, almost up to about 10% or less will be unknown to the victim. Okay, so males commit most of the sexual abuse, most of them are known to the victim. Rarely is it strangers, but it's the strangers that we hear about on our news programs and such. And so onward, and this talks really about the area of sexual abuse that can be a stranger to the child, and that is sex trafficking. Something very difficult to talk about. There's the definition there. I think it's important with that definition to know that these children are not typically kidnapped and placed into trafficking situations. They are exposed to someone, could be someone known or unknown, who uses their willpower and control skills to gain control of this child. They can use threats of violence, they can use coercions, they can use inducements with prizes to do that. So it's not someone taking and kidnapping the child, and oftentimes these children still live at home. They might not be even away from home when this occurs, right? It is, though, a pediatric disease, and that's why I mentioned it to you. 71% are adults. Women, let me rephrase that, 71% are women. That includes some children. 25% are children there. But notice that the peak age at the onset is the 15 to 17-year-old age range. And so it is a pediatric problem that we have to be aware of. I'm fortunate to work at our CHIP Center, where they've developed a trafficking survivor program where we provide medical care for trafficking survivors. There's lots of things that go into placing a child at risk for trafficking. So there are the individual factors, so it might be some things about that individual. There are the more societal factors, right? So things that the society puts in there. There's interpersonal within that family that goes on, and then there's community factors. And so you can see all those boxes. And so the point of that is that, we can change some of those factors for the better or for the worse, as a society, as people who care. And COVID is an example of that. We oftentimes depend on school teachers, people in the community who notice when things are wrong with children. And so with the COVID lockdowns, and children were locked in their homes, sometimes with abusive parents, abusive neighbors and strangers, there was no one available to detect that. So after the initial shutdown, the reports of sexual violence, the reports of physical violence in children, the episodes of that, the reports of recruitment with online trafficking for children skyrocketed. Because of this community societal shift, we went into a lockdown mode. So we are in control as a society of lessening or inadvertently increasing these factors. So something to note. All right. All right, so take a breath for a second, because I'm going to get a sip of water. A little humor interlude there, so we all hope it's the ice cream man and not the vaccination man when they come down our street. You can close your eyes for 15 or 20 seconds and go to your happy place if you need to. That concludes our part about sexual abuse. We're now going to move on to physical abuse. If you have any questions, I do believe you can email them to the coordinator and I can answer them later. But don't forget your happy place. All right. Okay. Hopefully you guys have taken a brief mental respite. And now we're going to move on to our physical abuse myths. Okay. First, we're going to talk about bruising. So they're little babies. They might bruise easily. That's why they have a bruise. Oh, it's easy when people are playing with babies that they might get a shaken baby. And they're such nice parents. They would never hurt their babies. And they must be little and have really brittle bones because they're such little things. So those bones must break easily. Right? And similar, if you're a doctor, you should be able to identify abusive injuries. All these are myths, right? And if there's no bruising, the kid must not be injured at all. Okay, so we're going to talk about those myths a little bit and onward. So cute little baby, not mine there, but they really don't bruise easily. They actually are just the opposite. It's harder to bruise a baby than to bruise someone my age. They have very elastic skin. all right? And so their injury threshold is higher, and so they don't get bruises when they move around in general. So there's a seminal paper in our field that was titled "Those Who Don't Cruise Rarely Bruise." So cruising is a 9-month milestone, and so babies will start moving around then, and then they can fall, and sometimes they will get bruises. We know where those bruises should occur. But if they're not moving around much, there's no good reason for them to have a bruise in the absence of a immediately disclosed specific traumatic history. Accidents do occur. Parents do drop their babies or let them slip out of their bouncy seat, which happened to my baby daughter. So they do happen, but as medical providers, we have to be able to detect when we should expect bruises, when not, and what we should do about them. The next thing is that oftentimes there are injuries without bruising. So this looked at a series of infants who just had bruising. Medical examination did not show any other evidence of injury. All right. There is a standard workup for child abuse that we do that I will talk about. One thing is called the skeletal survey, and a quarter of them had broken bones, even though they didn't look like it. Neuroimaging, a CAT scan, which we do in a lot of cases, a quarter of them had brain injury. A small percentage of them had abdominal injury. All right, but in total, at least 50% had at least one additional injury. And why that's important is that there is a medical workup of children with suspicions for abuse that must be done if you're going to detect the other injuries that will occur. Right? The other mythology about bruising is they used to think we could tell how old a bruise was. Doctor, how old was that bruise? It became important because he just came home from non-custodian's care and had a bruise. Custodian said it happened at mama's house. Non-custodian said, mama said it happened at the non-custodian's house, back and forth. And so then they would say, hey doctor, how old is that bruise? And we would try to detect that. We can't. It turns out that the colors of bruises vary depending on depth, body color, body pigmentation, depth of the bruise, the bone that it's under. All right, so we cannot determine the ages of bruise. Okay, but we can determine the meaning of bruises. So we now know how to classify bruises. We use this thing called 10-4 faces. P is our mnemonic. What we know is that children, and I'll go back to this picture before, notice these bruises. Those are normal bruises, right? And if I see a toddler that doesn't have bruises like that in my practice, then I know they've been playing video games and watching too much television. Children should have bruises on their shins. But we know that the 10 stands for torso, trunk, ears, neck, right? And areas of the face, the frenulum, the things that hold your lips there, the angle of the jaw, the cheeks, the eyelids, the eyeballs, they should not have bruises in the overwhelming majority of accidental trauma. And since they're not moving at all, infants that are 4 months and younger shouldn't have any bruising at all in the rare history of a trauma. And so when we're teaching medical providers to evaluate bruises, we teach them to say, you see the shin bruises and they're a toddler, then you're not worried about that. But if you see a big bruise on the cheek and one on the stomach, then you should be more worried about that. And then the P stands for pattern bruising. So I must show you one picture what I mean by a pattern. It's very helpful for us. So the picture on the right is a pattern. You notice there's these linear marks on these patterns. There's sharp, distinct borders on these bruises. That doesn't occur with accidental trauma. So we know that a child like that would have been hit with something. What that object might be, we can determine that sometimes based on the pattern. Or sometimes there's even handprints. We know that when fingers contact the skin, they can give the outlines of fingers. And so we see children that have handprints on their body, so we know that they were slapped or hit and such. So the 10-4 faces, P, those things help us evaluate younger children, in particular with bruises, to help determine whether abuse might be possible or not. Once they're a teenager with their skateboard, all bets are off, right? They can bruise anywhere and everywhere. So we're really talking about young children. Okay. I'm now going to, this is your trigger warning. I'm now going to show you in the next 2 slides, kind of, for me, I think is the most disturbing content, but I think it's really critical for people to see to really understand how abusive head trauma occurs. All right. So this is a crying baby, okay? Crying, getting on everyone's last nerve, right? And what crying babies do to parents, particularly parents that are tired, stressed, exhausted, who might, for other reasons, not have a lot of impulse control, is trigger reactions that can harm that baby. All right? And that reaction is something we call now abusive head trauma. And quickly, this CAT scan, this is a severely brain injured child. These are subdural hematomas with brain swelling there. The way it looks on the right here, it should look like that way on the left, but there's such brain swelling. This does not occur from accidental trauma, right? This requires a significant rotational force on that child's brain. So it would occur if a child was ejected from a moving vehicle at 65 miles per hour, but we know that, right? But when a 4-month-old shows up in the emergency department with those type of injuries, they're typically very sick, comatose, having seizures, things like that. We know something like this has happened to them. And this is a disturbing injury. This is what happens with abusive head trauma in infants and young babies. So this does not occur from bouncing on grandfather's knee or from rolling off the sofa. This occurs because the child's either been grabbed or grabbed and thrown. And notice that to be grabbed, there can be some squeezing that causes rib fractures, all right? There's a rapid movement of the child's head back and forth, causing the brain to move, that tears nerve cells and blood vessels, okay? And the extremities can flail back and forth that causes fractures, particularly at the joint lines on those extremities. This can happen when a child is thrown. This can happen when a child is punched, all right? Most people used to know it as shaken baby syndrome. We do not use that term anymore. So that's kind of a mythology anymore, because when you see a child that shows up with the constellation of injuries that comes from abusive trauma, they're not always shaken. Sometimes they can be thrown, sometimes they can be punched, compressed, squeezed, right? So we use abusive head trauma, right? Abusive head trauma encompasses all those things that can unfortunately happen to an infant and young child, all right? So no more usage of shaken baby syndrome. We don't use that term anymore, all right? Brain injuries occur because of this movement of the child's brain, all right? All that other movement causes bleeding behind the eye. You've probably heard of retinal hemorrhages, okay? Rib fractures, which happen to be pretty specific for abusive trauma, or metaphyseal fractures, or which are kind of chip fractures at the ends of babies' bones, all right? So we sometimes see all this together, and we see these together, you know, unless there was a proven history of being ejected from a moving vehicle at 65 miles per hour, or something like that, then we know that this child has been victimized by abusive trauma, all right? Unfortunately, prevention is really important, because when this does occur, it's very severe. About a quarter of the children with abusive brain injuries die, and about 80% of them will have permanent brain damage from that. So it's really important for us as a society to respond and diagnose these, okay? So where does this occur, all right? Where does this happen to children? These are horrible injuries, right? Well, there's this belief that this only happens in these families that we arbitrarily consider not nice. It might be because there is drug addiction. It might be because there's severe poverty. It might be for a host of factors. But what we know, that child abuse occurs in all types of families across the spectrum, and no socioeconomic group is protected from this, okay? I like to talk about this study because I think this hammers home that point. And that is the fact it looked at 173 children whose abusive head trauma was missed by the initial evaluating physician. They did not make the right doctor, all right? They did not make the right call. In 54 of those, all right, they compared them to the ones that were not missed, Okay, so they compared the ones that got missed to the ones that were not missed. Okay, and they said, what was different about those children that got missed? And that's an important question, because of the ones that got missed, a quarter of them got re-injured and 4 of those died. Okay, what was different? Okay, and they found 2 things that were different about the kids that got missed and did not get missed. The ones that got missed tended to be younger, and they had non-specific symptoms. So they were maybe a little more fussy, a little sleepier, and maybe the medical provider said, well, they're teething, or they have an ear infection, or they have colic. All right? But the other one was very sobering. The other reason that they got missed is that those children came from white, intact, upper middle class families. They came from families that medical providers would typically consider nice families. So speaking to the inherent racism that occurs in all medical providers, that we sometimes make judgments based on backgrounds and such, but also speaking to that point that I made, is that abusive trauma occurs across the spectrum, and that nice parents hurt their babies too. Right? Been accused in court of just trying to diagnose child abuse, because I'm a child abuse pediatrician, but injuries do occur from simple falls. We know how those injuries are different from abusive injuries. Emergency doctors, anyone working with children, are trained to kind of detect those differences. We know, based on their developmental level, the injury mechanism that was occurred, that was reported to us, what the injury was. We can stratify those into their likelihood about abuse. And so we're out. I love when I can diagnose an accidental injury in a child and treat that injury appropriately and don't have to consider child abuse. All right. I'm going to move on to fractures. And so there are myths about fractures. So some people hear spiral fracture and they think, oh, that's abuse. I was taught that when I was being trained. All right, babies' bones break easily, just like their skin. They don't break easily, and oftentimes there's no bruises even when there's fractures there. So we know about fractures is that there's some fractures that typically only occur in abuse. Those things I was talking about with abusive head trauma, like those corner fractures, metaphyseal fractures, or rib fractures, right? When we see a child with lots of fractures, or they've clearly been injured more than once, that can be very concerning. But we know there's fractures that occur all the time in infants and young children when they fall or even get dropped. If they land on their shoulder, they get a clavicle fracture, your collarbone. There's a fracture known for toddlers called the toddler's fracture, which is a spiral fracture of their lower leg bone, the tibia, that happens anytime you plant, you're moving, you plant, and you twist. That's what toddlers do all the time. They're running and they change direction. So they have a fracture named after them. When I see that in a 2-year-old who's been out running around, that does not cause concern for me. So the role of people who work with children and to be able to detect abuse is to be able to distinguish those fractures. And we can distinguish fractures based on how they look sometimes. So this is your classic spiral fracture on the left. This is a transverse fracture in the middle, and this is what's known as a loading fracture, an impact fracture here. We know how those occur. And so when I see a child with those fractures and I know the history, I can determine, what's the likelihood of that history is a viable history to explain that child's injury. Again, when I see a 4-month-old with a fracture of any type, without a very specific detailed history of accidental trauma, then that's highly suspicious for abuse, as opposed to the 4-year-old who was running all out in the field and comes back limping. And then we know that there's a good story for that. Okay, we can help date fractures because there are stages of healing. The stages of healing, they go from the fracture line to some fuzzy bone growth around it that then becomes much more solid. And so there's a timeline for that. So if you look at, and I love this slide just because it shows how miraculous the body is, but if you look at what an acute fracture looks like, just happened, we know that that's within just a few days, as opposed to what we call that callus formation, where this new bone's starting to bridge that gap. And we know that starts to occur within 10 days to 2 weeks. So when I see a bone with fracture with callus on it, I know it's at least that old. To really within as little as 4 months in infants, to you can't even tell it was there. So pretty miraculous that healing. That helps us be able to determine the age of a fracture and how it relates to the history that's been given. Okay. How we detect these fractures is something called a skeletal survey, and that is a detailed view of every bone in the child when we are evaluating a child for suspected abuse. Okay, it can be repeated in 2 weeks because sometimes the initial one will miss one, and it's important, as I said, because young children, infants, do not localize pain. They do not show fractures when they are present, and so it's important for us to look for them. Right? So basically, anyone with suspicions for abuse under the age of 2 needs a skeletal survey. If they're a little bit older and they have clinical evidence of multiple skeletal injury, they need a skeletal survey. Don't do a whole lot in kids over 4, but it's an important tool for us. Along with that, if they're really young, I'll need a CAT scan of their head because of the potential for brain injury. And if there's concern for abdominal or organ injury, either because of abnormal blood work or some bruising there, that even a CAT scan of the abdomen becomes an important part. Additionally, there's panels of blood work that we do that look for bleeding problems, that look for internal injury. So all those are somewhat typical for someone who's evaluating a child for abuse to be able to perform. Okay, so no fracture proves abuse. All right, so it's putting the kid's age, their developmental level, the fracture that we see, the mechanism that was reported to us to help determine. Okay, abusive fractures occur more commonly in infants, all right, in young children. Multiple fractures make us worried, and we still have to consider medical mimics there. So because I only have 5 more minutes, and I knew that, we omitted some stuff. So we're not talking about child neglect, which is the most common cause of abuse. You think about severe dental decay, failure to thrive, immunization, omission, things such as that. Burns, which is a common cause of punishing toddlers for toileting accidents. Abdominal trauma, it's less common, but it's the second most common fatal cause of child abuse, fatal outcome in child abuse. It's less rare. Head trauma is the most common cause. Skin injuries are the most common cause. And then something called caregiver fabricated illness, very difficult to diagnose, where a parent or guardian will actually inflict trauma on that child. Very difficult. You can send your questions, we discuss. We have a couple more myths to talk about. You can read through these and know these are all myths, all right? Children don't usually tell, they don't usually make up stories, all right? Some children have normal sexual behavior that is normal. We know how to separate that from the sexual behavior that comes from abuse. Child molesters look just like us, we can't tell. People who self-identify as LGBTQ are not more likely to cause sexual abuse, and in fact, some studies are less likely. Disabled children are more vulnerable, all right? Children oftentimes tell and sometimes recant. Most of the time they're not lying. Children rarely lie about abuse. And most perpetrators are living in our society without overt evidence of mental illness or without diagnoses of mental illness. Fortunately, most abused children do not become abusers themselves when appropriately detected and appropriate counseling. Unfortunately, physical abuse is about half and half. Men and women carry that out. So unlike sexual abuse, which is mostly men, physical punishment can lead to abuse, and the data is pretty clear now that physical punishment does not help control children's behaviors. So you will not find any child abuse pediatricians that support physical punishment. Abusive parents do love their children, and oftentimes, particularly with younger children, it is impulse control problems, right? And was not premeditated, all right? And children do not cause their own harm. Yes, they get on every parent's last nerve at times, but they don't cause the abuse. Right? Children are being children, and that should not provoke abuse. We talked about the adverse childhood experiences. We hope that some experiences they can recover from with the appropriate resilience and supportive communities that help detect this abuse, help them get appropriate treatment, and help them recover. But children sometimes have lifelong health problems from this. And that's the end of the content. I know most of you probably have full brains and full stomachs from this, so this is no more content, but if you have questions, you want to get a little bit more content, please reach out. And don't forget your happy place. That's my happy place. That's the Little River Canyon. When I'm in live audiences, I'll raise a hand and ask how many people have been to the Little River Canyon, and very few. But it's North Alabama, Lookout Mountain, the largest canyon, one of the largest canyons east of the Grand Canyon, and it's a beautiful natural area. So if your happy place is out in nature, I highly recommend that you visit it at some point. Thank you very much for listening, and I hope this empowers you to help protect a child and change their lives.
Hi, I'm Mark Bailey. I appreciate your asking me to speak today on controlled substance guidelines. This is obviously a rapidly evolving area. It seems like every time I do this talk I have to revise it. But I am a neurologist at Baseline. I'm a certified pain doc as well. I do medical pain management, so the perspective of this presentation is that of a medical management pain doc. I have no conflicts of interest. I don't think I'm talking about anything off-label. Interesting that my slides transparency on the backgrounds didn't work. But anyway, this is Dr. Simon Bar-Sinister. He's going to help me out over the course of this presentation. He was, for those of you old enough to remember Saturday morning cartoons, he was the evil nemesis of Underdog. He is now an esteemed neurologist scholar and is the patron saint of UAB neurology. You can see he's a neurologist, right? He's got a long white coat, a little black bag, Tromner hammer, bow tie. He's got the package. Okay, first just a few housekeeping kinds of definitions. Chronic pain is anything that lasts more than a month. Acute pain is anything that lasts less than a week. The concept of morphine equivalent dosing, and it gets abbreviated in lots of different ways, MEQs, OMEs, all the same thing. It's how much morphine or the equivalent of morphine you take in a 24-hour period of time. It is the currency of pain medicine. Opioid risk, there's two sort of prongs to the opioid risk. It is a thing that you need to assess with each time you see a patient and write pain meds for them. Part of it is how likely are they to use it in a non-prescribed fashion, and that speaks for itself, I think. There are obviously other factors that make writing opioids risky, and that includes respiratory depression. I mean, there's a lot of factors that could increase the risk of taking opioids. Benzos on board as well, that's a big risk increasing factor. So all of that gets rolled into the opioid risk term, and usually in our notes we express these as low, moderate, or high risk. And what we do with that information is based up, your call. I personally use that to decide how often to drug screen my patients. Pain is the number one reason people seek medical attention. It is an experience rather than exactly the same as, tissue damage. And the example that I like to give to highlight this is the football game. Let's say that two big rival teams are playing each other. You've got big money on one of them. The game is in the fourth quarter. The score is tied. It's a very tense thing. And then I sneak up on you with a hammer and bop your toe. A lot of stuff happens. Tissue damage occurs. Neural signals gets transduced and sent up to the spinal cord where some processing happens. Heads up to the brainstem and brain where more processing happens, and voila, you experience pain. Well, you turn and shake your fist and say and think naughty things about Bailey, but then something happens on the TV, a big play happened, and you're back to it. Didn't end up being that big a deal. Now we'll paint the picture. The next day, your team lost. You lost a bunch of money. You drank too much. Weather is crummy outside. Your hair's not working, etc. It's a bad day. Now I sneak up on you. Same hammer, same toe, same tissue damage, same neural signals, but it hurts a lot worse. And that's sort of the point here, is that the experienced pain may have something to do with it. Well, it probably has something to do with the hammer and the toe, but it's not the same thing. It's the experience. And that's something we have to keep in mind when we're treating pain. particularly chronic pain. Overview of the things that we'll be talking about, some little bit about opioid basics, some about the effectiveness of opioids, when to use them, and then we're going to talk about some trends in pain management, particularly medical pain management, as well as some Bailey's prognostications. So this is some of the basics. Again, here's Dr. Barsinister helping me out. Opioid taxonomy. There are lots of ways to divide up opioids. Synthetic, semi-synthetic, and natural is one way of doing it. And I know you're thinking to yourself, well, who cares? What difference does that make? It is not purely an academic exercise. If you've got a patient on, pick a drug, hydrocodone, and their pain control is inadequate and you're thinking you need to change it somehow, you've got a lot better chance of reestablishing pain control if you will step outside of the major group. So hydrocodone is semi-synthetic. You would do much better to switch to either one of the purely synthetic or the natural opiates rather than switching within the semi-synthetic round. Just a guideline. There's nothing that says you can't switch somebody from Norco to Percocet. You can, and obviously the oxycodone is more potent, but I'm just telling you that your likelihood of long-term success is better if you'll switch outside the major categories. And if you switched from a semi-synthetic to a natural to a purely synthetic and the patient still doesn't get pain relief, I think you're well justified in saying this patient's pain is not opioid sensitive, and you have reason for doing that. Duration of action, almost all of them are short acting, and we all know that, and usually by short acting we mean 3.5 hours or so. The one long acting medicine that gets used a lot is methadone, and it's got a half-life of 28 hours, excuse me. It doesn't provide analgesia for 28 hours. It's about an 8-hour drug for analgesia, but it is natively long-acting. There are obviously ER formulations of almost all the short-acting drugs, and it makes them kind of act like a long-acting agent, but the chemical itself is short-acting. There is no science that says long-acting is better than short-acting or vice versa. We're kind of short on science for a lot of our opioid prescribing, but that certainly is true, that we've got no way of knowing, or we don't have any science that says long-acting is better than short-acting. Now, a lot of our guidelines, particularly in the past, they've kind of backed off on some of this, but most of them advise starting off with low doses of the short-acting agents. And I don't disagree with that. I mean, I think that's fine, but it's not because immediate release drugs are better than long-acting agents. That's just not the case. Agonists, we all know the agonist here. The weak versus strong business, that's not language that's used anymore, just forget that. Obviously, tramadol is not as strong as morphine on a milligram basis, but the terms weak and strong are probably not, they're just not used. These are pure agonists. The one that's kind of an oddball here is the Imodium, the loperamide. It is an opioid agonist. We don't think of it that way. We think of it, as treating diarrhea. Well, what do opioids do in the gut? They shut down or stop peristalsis. The peripheral only tag on the Imodium is that it does not cross the blood-brain barrier. Therefore, it does not interfere with pain drugs that do need to get into the CNS to do most of their work anyway. But it's just a thing to remember, is that Imodium is a mu agonist. Partial agonist. The top three on the list are agonist-antagonist pairs. Buprenorphine is just a partial agonist natively. The top three are older drugs. They're hardly ever used anymore. The thought was that the agonist was going to do the pain relieving, and the antagonist was going to help out with the side effects, respiratory depression, constipation, etc. Didn't really work out all that great. Stadol rarely see it used in the form of a nose spray for migraine abortive. Nubane, I see OB folks use this every now and again. I don't remember the last pentazocine script I've seen written or used. Buprenorphine certainly can be used for pain. There's a couple of pain preparations, and even the ones that are mostly designed for use disorders can be used for pain, but that's kind of a separate issue. Now, the difference in a partial and a full agonist is that at some point you can give more and more drug, but you won't get more benefit. You won't get more analgesia. They have a ceiling effect. This slide was taken from the use disorder literature, and so it uses methadone as the prototype full agonist and buprenorphine as the partial agonist. But that's what that means. They have a ceiling that giving more will not produce more pain relief. There are some pure antagonists. We know, Narcan, we all know about. Narcan nose spray. In my clinic, everybody that gets a pain medicine gets a prescription for Narcan nose spray to reverse in case of overdose. These are the centrally acting ones. There are some peripheral only acting antagonists, and these work in the gut primarily to reverse the opioid shutting off of peristalsis. Essentially, they are I guess you would call them laxatives in that way. They will work. They do work. My patients, I don't have a lot of patients who I've written these agents for because they're pretty fierce. My patients tell me that, yep, doc, they work, but you better be standing by the bathroom when you take it because it's about to work. In fact, so much so that they prefer over-the-counter stuff rather than going to this level. So yes, these are peripheral, working in the gut antagonists. Some of our opioids work at multiple receptors. I'm going to go through this pretty quickly. Tapentadol, which is our newest chemical as far as pain drugs go, is both mu receptor agonist and SNRI-like, and it is an adrenergic reuptake inhibitor. Those are the descending pain pathways that bank down the effects of incoming pain signals. So, I mean, that sounds like a really good thing, that it would take care of pain going and coming. It does. I was really excited when this first came out, but it's kind of turned into another opioid option, not better than the other ones, just another option if you can get it past insurance, because obviously it's a new drug and somebody's got to pay for it. Methadone is opioid mu agonist. It also is an NMDA receptor antagonist. NMDA receptors are involved in the slow burn, C-fiber pain, and and those are mostly like purely neuropathic pain kinds of things. And methadone is a potent NMDA receptor antagonist. There are other weaker ones. Ketamine is a stronger one. Dextromethorphan is a weak NMDA receptor antagonist. For that reason, we sometimes think that methadone might be a better agent for purely neuropathic pain, diabetic neuropathies, or CIDP, the inflammatory, like the chronic Guillain-Barré form. which is more painful. Guillain-Barré is mostly motor, and the CIDP is, can have very prominent sensory components. Tramadol sits on a lot of receptors. It's on mu receptors, may be anti-inflammatory, may be antidepressant. Well, why isn't that? I mean, that all sounds great, right? From the pain doc standpoint, that's what you would want. It's just a weak mu agonist is the problem. It's just not very strong. And most of the time, when patients come to my office, they've been there and done that. A couple of the commonly used pain drugs are prodrugs. They are not natively analgesic in and of themselves. And this is kind of a surprise to some folks. Hydrocodone, a very commonly used one, is not natively analgesic. It requires liver activation before it turns into hydromorphone, which is its active form. Codeine is metabolized into morphine. Tramadol is inactive until it's converted into the, chicken wire with a funny name, tramadol product. So who cares? Why does this matter? Everybody's got a liver. Well, most everybody does. Not everybody's works as good as it ought to. And if your patient has got cirrhosis and maybe doesn't have two P450s to row together, you could probably still get analgesia out of hydrocodone with such a patient, but you'd have to give them more doses than most of us are comfortable writing. Much better to just switch to an agent that is natively active and does not require liver activation for pain control. Okay, a little bit of historical perspective. Excuse me a second. Let's pause it, please, just for a second. I'm sorry, I'm going to have. Sorry about the break. Got a bum foot and had to find somewhere to sit. Okay, so historical perspective, most of us are aware of some of the crazy roller coaster ride that pain management and opioids in particular have been over the years. Starting somewhere around 2000, the public opinion was that doctors were not treating pain aggressively enough and that people were dying in pain, and that was obviously an awful thing. And so public outcry, political action, we got lots of things that came on board, like the Joint Commission bringing us the fifth vital sign as a mean to address pain on the inpatient setting. This was really had so much negative repercussions. It turned out to be a lousy way to do things because, I mean, let's face it, in the hospital setting, the nurse goes in and has to wake up a patient who's deeply asleep and ask him what is pain, and he kind of mumbles 8. And so she goes scurrying back to the MARs and, gets a bunch of morphine and comes in and gives it to him. Well, he's back asleep, so she has to wake him up to give him his 8 of 10 pain meds. He's over-medicated. And that's not at all uncommon. Many of the big medical groups ask that we remove these from hospital protocols. To my knowledge, the Joint Commission hasn't done so, and I'm pretty sure that pain is still the fifth vital sign, and there's lots of orders being written out there. If pain is greater than 8, then do this. in the past, we were taught that the dose response curve for opioids was linear. You hurt more, you give them more drug. Eventually, you either get pain relief or unacceptable side effects. That's hardly ever done, but 20 years ago, what was being taught to young pain doctors was that somebody came in with pain, you gave them a big bottle of immediate release, pick a drug, say morphine, and you told them to eat as much as they wanted to and come back in a week. Well, they came back in a week and they said, well, how many did you take in most days? And they said, well, 10. Okay, so then you would take the milligrams of 10 of whatever you were giving them and convert that into long actings, but then you still gave them the big bottle of short actings and said, take the long actings, but also you'll have the short actings, as much as you want, and then come back in a week and tell me. Well, you see where I'm going here. The idea was to convert the short acting to the long acting. But I would say it'd be close to malpractice to be handling things that way now. I mean, I can't imagine handing any of my pain patients a big bottle of morphine and telling them to eat all they want. That's just not how we practice pain medicine anymore. But it just shows how we've changed. Now, we've, since the increase in pain medicine usage, starting again at about 2000, there have been consequences. We've used more pain medicine, there have been more people die of overdoses, and then starting around, somewhere around 2010, the realization came that a lot of people were dying of overdoses, and the opioid epidemic was proclaimed. And then we had rules and regs and guidelines, CDC guidelines as being one of the big ones, but more than that, state guidelines, state law, that doctors were writing too much medicine and we had to be educated on how to properly do it. This slide is probably one of the more important out of this deck. The green area is how much stuff you and me wrote. That's how much pain medicine was prescribed. And you see down to the left, and around 2000 wasn't too bad, and then we were told that opioids weren't dangerous when prescribed for true pain and under medical supervision and so forth, that addiction wasn't, that it was a tiny fraction, that didn't really happen all that much. And so, our friends at Purdue came around to see us waving these pieces of paper that were proving that this was the case and it was okay to treat their pain aggressively, and they did much better and so forth. The black line there is a combo of all opioids, and that's the death rate, the overdose death rate. And that doesn't surprise me too much. We're writing more meds, and so more people are dying of overdoses. That's kind of what that line says. But then in 2010, when we started writing a whole lot less because rules, regs, guidelines, better understanding of how things worked, whatever, we started writing less medicines. Doctors are reasonable folk, and so when they said, oh, well, my goodness, we're killing people, we got to do something, okay. So you see the green line start to fall. We did exactly what we were supposed to be doing and what the indications were that we should be doing. Trouble is, that didn't fix the problem. You can see the black line did not taper down to parallel the green one. In fact, it skyrocketed. The learning point out of that one is that all the rules, regs, guidelines, etc. did not fix the opioid epidemic problem. Probably made it worse. Now what happened here is that the drug of choice changed. Whereas before maybe prescription painkillers were the main source of the folks that were overdosing, when that became harder and harder to do, they reached to the street, and street synthetic opioids are the major culprit in the skyrocketing overdose death rate. Here is a kind of a snapshot through time of how much opioids were prescribed. And remember, this is how much is prescribed, not overdose deaths. You see the Deep South has got a pretty heavy-duty prescribing habit there, and a lot of other places too, but Appalachia, we wrote a lot of pain medicines in 2010. Well, by 2015 and then 18 and then 20, you see that the amount is decreasing. Not as much in those Appalachian areas as the rest of the nation, but still it's a pattern that we all see, and this is what the graph earlier said. We're writing less pain medicines. Now this is overdose deaths. Dr. Bar-Sinister is pointing to California there with over 6,000 deaths, and this is last year. Whatever state you're in, you can probably see how many overdose deaths. In general, overdose deaths they're kind of leveling out. My state is Alabama, and we increased last year, not by a lot, but it did increase. And this is the piece of paper I was talking about that the pharmaceuticals were waving around. This is an opinion piece in a journal in JAMA, published in 1980, and I mean you can see what it says, that not the risk is low of addiction. Well, this was an opinion piece, but this was pointed to and used as science to support more aggressive treatment of pain. Currently, it's hard to put a number on how risky opioids are for producing use disorders. There's probably between 10 and 30%, and that's a huge number. I mean, you think of any other drug that's got a potentially lethal side effect between 10 and 30%. I mean, we don't use them much, right? I mean, that's a big side effect and a potentially lethal side effect amount. Benzos and opioids is an extremely hot button item, obviously. Benzos are respiratory depressants. Opioids are respiratory depressants. They are synergistic. There are other drugs that do the same thing, but benzos have been kind of singled out, at least from the forensic and regulatory side, and call me a pessimist, but I think this is just because it's an easy metric to grab. You can go to the PDMP and see how many patients are being prescribed benzos and how many opioids and how much overlap there is there. But this is something that is being kept up with. Your state PDMP knows exactly who the top opioid prescribers. They can tell you exactly how many patients you prescribe opioids that also get benzos, not even necessarily from you. Benzos could come from another provider, but you're being kept up with there. And if there was anything from a medical legal standpoint I would encourage you to pay attention to, it's this benzo and opioid combination. Doesn't mean that someone on benzos can't get opioids. I have some patients who have spinal cord injuries, who have dystonias that require a benzo and that they have a painful situation, but it needs to be in the chart somewhere that the benzo is necessary, that alternatives have failed, and that quality of life dictates that we have to use both benzos and opioids. Fentanyl is obviously a high potency agent, and just in case somebody lives under a rock and doesn't realize, this is not your grandmother's Duragesic patch that we're talking about here. We're talking about kilo blocks of fentanyl coming from overseas. This slide I borrowed from and put borrowed in air quotes there, from a Homeland Security agent. And his concern was that a pinhole in one of these kilo blocks of fentanyl if this agent squeezed it, could enough be aerosolized and whiffed into the air to potentially hurt somebody? Well, there's a penny, there's a potentially lethal dose of fentanyl, and I would say the answer is absolutely yes. If you inhaled sharply, I mean, you would get a big bunch of fentanyl if you had an open wound or any other way for the fentanyl to get into your system. So yes, it is a high potency agent, and tiny amounts are potentially lethal. Gabapentin is an interesting one that we've realized also has a role in respiratory depression, and it seems to be only in combo with opioids. It doesn't seem to happen just if it was given by itself. But gabapentin combined with opioids can markedly increase the risk of respiratory arrest and death. It's, like I said, dose dependent. The higher amounts of gabapentin, the higher amount of opioid, it can be up to 60% increase. Doesn't mean you can't use gabapentin, it just means that's a risky thing that you need to take into account. Opioid effectiveness. They are among our most powerful analgesics. You break your leg, somebody gives you morphine, that works. We got that. The trouble is more with the chronic, which is more than a month. We don't have good science that says long-term use of opioids is effective for chronic pain. We do it. I have lots of patients who are chronically prescribed opioids, but I'm very, very hesitant to do any dosage increases, and any chance I get, I'll cut the dose back, and any chance I get, I'll get rid of the opioids altogether, just because we're standing on such shaky ground from a data standpoint on that long-term use is appropriate for opioids. So when to prescribe them in current practice? I tell my pain fellows the number one rule of pain doctoring is that you got to have something wrong with you. And that seems silly, and it is, but you would be astounded how many people are on pain drugs because somebody took an x-ray 20 years ago and showed them some slip discus, and boom, Soma, Xanax, and Lortab, and they liked that, and it worked real good, and they've been prescribed it ever since. So what's wrong with that person? Well, it's probably more of a use disorder than it is a chronic pain situation. So you got to have something wrong with you. Rule number 2, just in case you're interested, is that whatever is wrong with you has got to be bad enough to justify whatever it is you're doing. So stubbed toes won't justify a big bottle of morphine. Again, silly, but you get the idea. So there's a lot of hoops to jump through if you're going to write opioids for your patients in this day and age. We've talked about IR versus ER formulations, how much minimal that you can possibly get away with, and it's probably not going to be enough to make most people happy. Expectation management is much more a part of what I do now than it ever was 10, 15 years ago. Well, doc, I still hurt. Well, how much good does your pain? Well, 80%, but I still hurt. The pain medicine doesn't fix anything. You still got a crummy back. If we got 80% improvement, then that's probably about the best any of us can hope for. Oh, well, okay. It happens at lots of visits. Now, in the past, I have seen patients on opioids at 3-month intervals and write them 3 one-month prescriptions for their scheduled agents. Currently, I do not, and for the past, since COVID really, everybody gets seen at 1-month intervals. I write 1-month prescriptions for everybody. The only exception to that is being people that I'm managing only with Tramadol or Tylenol-3 with codeine, that I can put a 2-month refill on there. Documentation requirements, you need to document there's something wrong with the patient. You need to do risk stratification, which is the next line there, and that's the low, medium, or high that we talked about before. Dose reduction can be dangerous. This is more of when a patient moves out of state and their old pain clinic was writing them just huge doses of pain medicine, and now they're in your waiting room wanting you to write the same, and you don't feel good about that. Lots of ways to handle that, but probably the wrong way is just to cut them back immediately to whatever you think is right. You need to talk to them, and if there's any reducing goes, it needs to be done slowly. People commit suicide at a much higher rate when they've had their pain meds just pulled out from under them. A lot of the things that we have good science for that says will help with chronic pain, and there's a list of them: cognitive behavioral, yoga, tai chi, acupuncture, meditation, all of that's great. We've got good science there, but most insurance won't cover that stuff. And so to tell your patient, well, you know, I know you've been on 4 Lortabs a day for most of your adult life, but we're not going to do that anymore. We're going to send you to a yoga class. Well, that you need to handle that with a little more deftness than that. And the patient will quite correctly ask you, well, will my insurance cover it? And of course the answer is no, it's not going to. That's unfortunate, and that's, I think, you know, folks not putting their money where their mouth is. Yes, it's great to say that we doctors ought to be not writing so much pain medicine. We ought to be using more of these excellent non-medication treatments. Great, you're right. Just pay for it. The exception here being the VA, and the VA has got all these things available, mindfulness, and I'm just jealous as I can be of my comrades over at the VA because they've got that stuff. And when I first heard about this, I just kind of chuckled and I said, those old rascals are not going to go for yoga classes, but I'm wrong. They do, they like them, they are able to come down on their meds. I mean, it's completely, it's proved this works. And even folks that have been on chronic opioids forever and maybe not be motivated too much to do anything else can be helped. How much pain medicine does it take to be risky from an overdose standpoint? Well, the line's pretty much a straight one. Unintentional overdose, the blue one there, is the one I'll let you look at. The more pain medicine you give, the more likely it is they're going to overdose. It's a pretty straight line. There's no sudden cutoff at any one level. It's just the higher the dose, the more risky it is. Okay, this was some of that stuff about abrupt tapering of opioids from the out-of-state pain clinic, et cetera. I don't think we need to go over that a second time. Now, there were some CDC guidelines in 2016 that were designed to provide guidance for primary care providers on proper prescribing of opioids. There were lots of problems with the CDC guidelines, and I ain't got time to go get on my soapbox and rail on all of this. But in the end, they realized that what they had done was being used in the wrong way and was causing more problems than it helped. So had another go round in November of last year. Revised guidelines came out, and there were some oversights that were fixed. The first one there, it applies to everybody, not just primary care providers, but dentists and nurse practitioners and PAs. Everybody that could write pain medicine, the guidelines apply to now. Promotes integrated pain management. Now this is the one that really just sets me on fire, because yes, absolutely, multidisciplinary, that's the way to go. Your outcomes are great. That's the way to do it, and that's what the revised guidelines say is the best thing to do. Again, put your money where your mouth is. Nobody will pay for this, except the VA. VA will pay for it. Payment of multimodal treatments, yes, that's what I'm talking about. Joint decision making, promotes the idea of you discussing with your patient cutting back on pain meds because there's no science that says the dosage they're on are going to help anything, and likely going to give them, increase their risk. Discussing that with the patient, not just unilaterally saying, my way or the highway, I'm going to cut you back to 3 pills a day, and if that's not good enough, then have a nice life. That's not how we need to be doing it. Removal of dosage ceilings. This was the original, the 2016 guidelines said that nobody needed to be on more than 50 and for sure not more than 90, and if you did, then you had to have it in the chart explicitly. These numbers got used, and they got taken up immediately by the third-party carriers. It was probably 2 weeks after the 16 guidelines came out that I got a denial of service from, I don't remember which carrier it was now, based on the CDC guidelines. So the government says nobody needs more than 50 morphine a day, so we're not covering it. Well, that's not what they said. That's not how it was supposed to do. It was an unintended consequence. But that was one thing that the revision was hopefully taking care of, and it did better. It's not great, but it did better as far as not naming specific numbers. The last thing here is that these were voluntary, that they are not supposed to be moved into state law, and a lot of the original ones were, and they are still there in Alabama, and I suspect lots of other places too. Whether or not this is too little too late, I suspect that it is, but like I said, a step in the right direction. So what do we need to do for pain management now? If it's not pills, that's not the right way to do it. Well, exercise, yep. Acupuncture, yep. Yoga, Tai Chi, manipulation, all these things have got good science, and this is what we need to be focusing on. Weight loss would have to be one of these kind of things, daily exercise, healthy lifestyle. So a patient comes into your office who weighs 350 pounds and she's, 40, knees are shot, hips are going bad, and it's all because of her weight, but to have the conversation that weight loss is the primary thing that we need to be focusing on for your pain management, that's hard. That's really very hard. Weight loss is hard. I send a lot of patients to our bariatric surgery center. Fortunately for us, the weight loss clinic is sort of the entry point for bariatric surgery. So they've got nutritionists and folks up there to help guide diets and things like that as well. But the idea that we need to be getting away from the script pad for how to fix chronic pain is a tough one for both us and our patients. So this is just real quick. This was going to be a separate presentation, and it wasn't worth doing a whole talk on it. But so if it's not opioids, what are we going to do with these folks? We're going to have to give them some kind of pill. So I looked it up and went through the data on, this is all pertaining to non-specific low back pain, not specific radicular, not specific trauma, just non-specific low back pain. How much good are our meds here? Opioids will work in the short term, we know that. Long term, we don't know that, and the risk of potentially lethal side effects are way up there. So it's kind of a question mark, and certainly things like drug tolerance and hyperalgesia and all those things will happen. So there are other reasons not to use opioids for pain meds long term. Anticonvulsants, and mostly we're talking gabapentin and pregabalin here, but we've got really pretty good data that they don't work. And I know what you're thinking, well, gabapentin, that's good for neuropathic pain, right? Well, how about a bad back that's mostly radicular? That's neuropathic. Well, they thought of this too, and they separated that bunch out, and it didn't have any better effect than placebo. So gabapentin, I used to be a for real neurologist. We were putting gabapentin in the water, right? So many things that we were treating with gabapentin. Well, Gabapentin has got two indications, postherpetic neuralgia and diabetic neuropathy, and I guess we just all decided, well, those are neuropathic pain. Gabapentin must be good for neuropathic pain. Well, for nonspecific low back pain and even radicular low back pain, that does not seem to be the case with good data. Antidepressants, the SNRIs, the Cymbaltas, there are benefits, but it's really very small. The evidence is low to very low for nonspecific low back pain. Muscle relaxer is about the same. I mean, they can help. They do have side effects, mostly make you sleepy, but they can help. Non-steroidals can help. In low doses, of course, we've got you have to say that yes, they also have GI and renal side effects, and you have to take that into account, particularly in older patients, but yes, they will help, better than Tylenol. Multimodal pain treatment, so this is the way to go, right? This is the one that's got all the good science, less complications, just nobody will pay for it. Now, some of the issues in pain management here lately are that less pain drugs are available. The pharmacy simply does not have them to sell to your patient. And there's some reasons that are listed here. I don't buy any of them. The one that I think is the opioid litigation. The drug distributors, the ones that sell the medicine to the drugstore, they're getting sued left and right and handling huge settlements. And in part of their settlement, they agreed to sell less pain meds to the drugstores. So pharmacies are capped in how much pain meds they can get. And if they start asking for too much, they could get red flagged and their entire supply canceled. So I bet it is 4 times a day at least a patient calls the office and said, my drugstore doesn't have my pain medicine. And by now, they all know this game, and they call around and found it somewhere and said, but Walmart across the street does, can you send it there? Yes, we can call and cancel the original and send it to the second Walmart. I never would have thought I'd seen the day when a patient had to hunt down their own medicines like this, but it is going on now, and it doesn't seem right to me, but it is happening. Okay, so just a little bit of prognostications. I think more and more we're going to have to see opioids as a treatment of last resort. Non-opioid treatment is going to have to be way forward in our minds what we do with these patients. Good health matters have got to be focused on. Both patients and physicians are going to have to get away from this pill for every symptom mentality. And patients are going to have to be more active. A lot of patients, when you tell them they got to get some more exercise, they've got to eat more, make better, healthier choices. Well, all I eat is lettuce and drink water, and well, how much exercise do you get? Well, you guys see where this is going. Mostly they want to watch Oprah more comfortably from their couch. That's what they want to do, and that just cannot be. If they want to, they've got to step up and take some responsibility for their own health care. The doctors can't fix everything with mo pills. Our current strategies, which is mostly regulating docs, has not really helped with overdose deaths. So the summary, I think we've been through all this before, nothing that we hadn't been sort of railing on here. This guy here is a pangolin. I saw a Nat Geo special on these guys. They're endangered. This one actually is a walking around. He walks around, but he holds his little front feet off the ground like a little T-Rex. They're anteaters. They can't hurt anything. But if you decide you needed a new philanthropic outlet, then just Google Save the Pangolin, send them $1, get the T-shirt, etc. Well, you can't see any of my contact information because of Dr. Barsinister there, but I'm sure that they'll be glad to send you that stuff, and that's you can see my phone number and fax. And if there's any questions or issues, I'd be glad to try to field them. Thank you for your kind